right, good evening. Great to have such a wonderful turnout. It's even approaching some standing room only, so it's really lovely to see everybody. I think the last time I had an opportunity to do something like this was pre-COVID. Perhaps that's part of the enthusiasm to see such a lovely turnout this evening, in addition to the good eats company and weather we have. Now, when I went to put together this talk, I'm glad that I had some family physician colleagues beside me to guide, because this is actually really a broad topic, and honestly this could be called part one. And so that's why we have a wide time for having questions. In particular, I'm going to stop about 20 minutes or so. April is going to flag me down, and then we're going to have a whole bunch of time for, thank you, for questions afterwards as well. So some off of the slide deck and go from there. Now, we'll try to do some active participation, so please be willing to throw your hands up. I won't call anyone up here unless you really want to. So let's start off. As indicated, I do have a neuromuscular fellowship, so a lot of experience with patients in that regard. But by nature of our clinic, got into doing some headaches and concussion, and seem to have a niche in towards chronic pain, particularly in the neurological bent. So some of that will be expressed here as we go through the talk. So first off, just to line up your mind about what we're going to cover tonight, one of the things here we want to advertise is connecting with your neurologist, okay? I don't know if people had a chance to pay attention to the rotating slides, but one of the things we want to make sure that the family physicians know is that they can use the RACE app to contact the neurologists on call. Okay, so this is, even if you don't take away anything else from this talk tonight, if you can have that RACE app in your mind as a means to connect with us, that's going to help our patients move forward in a timely fashion. Get to hear your lovely voice. I was just thinking how we should have some faces on referrals. But we're going to get a little bit of an inside look of what it means to be me triaging what is being sent. So that way you can know where you might expect your patient to land. We'll do a bit of localization of sensory changes and the like. I'm going to stress a little bit more on the non-pharmacological, and you'll find out why. And then we're going to talk about painful pharmaceuticals. So first off is nerve studies and triage. So as you may imagine, with any diagnostic test, there's going to be challenges. And so there's already the challenges of the anatomical localization based on the patients, right? They don't follow always that C6 nerve route. They get a bit of tingling that goes on and off. Maybe it's carpal tunnel, maybe it's ulnar, maybe it's both. And then we've got them in our actual clinic, and we're going to do nerve conduction studies. And I want you guys to throw up your hands and might maybe offer what you've seen as coming back on reports as limitations, or what you guys understand as limitations. So any hands, volunteers that want to put up an idea, what do you think is a limitation of nerve conduction studies, i.e. when we take our patients and stimulate the nerves at the surface of the skin? Wait time, yes, we're definitely working on that in many ways, okay? Thank you for that. Pain, yeah, so not everyone likes these, and especially when we get to the needle studies, you have to really serenade them into the process. All right, so that's great, because I want to know where we're starting from. And one of the aspects is, first of all, nerve conduction studies, when we're doing the stimulations, are from primarily elbow down, knee down. So that means when you're talking about requests about hot sections above the elbow and above the knee, we've got sparse studies in that regard. There are some, but that's sparse. There is the tolerance of the test, okay? Sometimes it's good to look at the YouTube video of what it's going to be, and sometimes it is not. There is elements about the body habitus. So if patients have scars, wounds, a lot of adipose tissue, the distance between the stimulator and the nerves can be quite distant. The farmers, the other individuals in the labor profession can also have very thick skin. And that not only means from the stimulator, but also from the recording electrode. So there could be some false sense of it being a neuropathy in the full extent. Okay? There's things in the middle of the winter, and in Edmonton, this was a big deal where I did my fellowship, but affecting the results here. I've got a needle when I do my EMG studies, and if I'm going into the deltoid, I might hit fibers that are perfectly fine, and then other fibers, not so much. So there is a sampling error that can certainly occur. So what the utility of your history, the patient's history, and the examination is going to give me a lot of ability to interpret these missing pieces or these factors, okay? And also, hopefully, at the end of tonight, give you some tools to maybe feel compelled that you can take some next steps of treatment as well. So the next part is imaging. And many of you may have been familiar with the fact that we all seem to break down as we age. And as a result, our imaging looks kind of crappy as we get older. And that doesn't proportionally mean that everyone has disability from, say, C7, or let's talk the common areas, C5-6 or C6-7 impingements on the canal or the nerve roots, okay? So as one of the questions that came up, typically I'm going to be more concerned about things that I see in the moderate to severe category when I see that. But it's great when you see moderate to severe narrowing at C6-7, left side, but they have right-sided symptoms. Or it's C5-6 that's impinged, and it's a C6-7 distribution. So what do you do there? So there's that difficulty with imaging, but again, we'll try to put it together through the grinder and get out on the other side. So this is a referral that I might see. This is a good referral that I see. I think it can even be better, but this is not unusual. So 88-year-old gentleman, peripheral neuropathy, coming from Ontario. He's got some worsening symptoms. I don't know what worsening exactly means there, but mobility issues and falling. So you got my attention as a neurologist here. And then not feeling his foot sometimes. Well, he's got neuropathy. So we've got some other things, celiac disease, that may be relevant as a potential etiology. He's got a knee replacement. I'm not going to belabor the cases too much beyond that, but just realizing that information is what I triage with, okay? And keep this one in mind when we actually talk about what the different triage lists look like. So first off, what I would like to see, and as much of this that you can, and I realize your time is tight, so be selective, but you can certainly, rather than say numbness in the hand, can you tell me where in the hand? How high? Does it go all the way up? When did it start? How bad has it been? And when you say bad, what functional change? Can they no longer work? Can they no longer be the caregiver for their loved one? That's what I'm really looking, and again, the greater dysfunction, the sooner that we're going to potentially see them. So other elements. For whatever reason, well, my colleague, I'm sure, in his bag here has a reflex hammer, but actually, hands up, who has a reflex hammer in their clinic rooms? Okay, lovely, love it, okay? And for those that don't, I would encourage you at least using your stethoscope to whack on some reflexes, okay? This can be a critical component about elevating the triage, okay? And the absence of reflexes, likewise, okay? So if I have a dropped reflex, that means more to me when you're making the referral as well. All right, so you don't necessarily have to give a whole pain clinic level, but definitely useful to start getting that direction. So this is what happens in the background. So ASAP, we are looking at motor weakness, and weakness that is severe and progressing, okay? So this means not the post-MVA that has some weak hand once in a while. It's not going to grab our attention as fruitfully. We want to know whether this person is suddenly not walking Is it a vasculitic issue? Is it a nerve, is it an impingement on a nerve root that has caused some problems? Is it perhaps an inflammatory condition, right? So something in the course of a month or 2 months post-vaccination, and now they're nearly bedbound or at least not working. We want to see trauma patients, and my colleague Dr. Ayman Shaheen's quite interested about this, working with our plastic surgery colleagues, because again, if you get a nerve that is cut or severely damaged and it's not healing appropriately, whether it's your wrist drop or a plexopathy strain, we may have some techniques to bridge the gap or facilitate healing, but those have to be seen within 6 months by our plastic surgery colleagues, which means even earlier by us. So ataxias, so they may not be weak, but if this guy or woman is bouncing like a ping pong game, like what I just heard from Dr. Ritz in the hospital, again, please send them our way and let us know that, okay, they're strong, but they're seeming to fall several times despite being 31 years old. So urgent. So this is where we just have things, anything like this, but slower, essentially, right? So maybe they've got just a focal area in the hand. You don't see any fasciculations or devastating atrophy. They can still do their things. Maybe they've had a nerve root impingement. You said, hey, take some analgesics, maybe see some physio, take it easy, but it just hasn't recovered as well as you expect, okay? And then there's these elevated hyper-CKemias. Please make sure it's more than one CKemia or one CK level that's elevated. Routine-wise is, again, you kind of got the drift of post-MVAs aren't going to get high priority, but there are a subset that can. And then your peripheral neuropathies that are particularly slow, progressive, the idiopathic so called, and then some of our pre-existing known, genetically confirmed, like Charcot-Marie tooth, which may be a word that hasn't entered your ears for some time. Okay, so when to order in another fashion. Okay, so we've had kind of symptom evolution. Specifically, when you examine, there may be a couple of other things. So number one is if there's a clear asymmetry in the examination. Okay, so I want you to think in the context of, let's say, a polyneuropathy. You see this person says, oh, I'm having numbness in the legs and I'm having some trouble walking around. I can't walk quite as far. And then you go and do the exam, but you see that there's very much a clear difference from side to side with their dorsiflexion or their hip flexion, okay? And that starts barking up the alley of maybe a plexopathy, a mononeuritis multiplex, something that colleagues like myself and my colleagues can potentially do something about to start reversing. We have motor weakness that's more aggressive than what they're talking about by sensation. As I mentioned, maybe some more proximal involvement, which again may bring us into the categories of a myopathy or an inflammatory neuropathy. And rapid progression, as we've referred to. So our first Slido question. So if you guys want to log in, or at least mentally, please check in. So we've got which of the following needs nerve conductions/EMG? So we've got patient 1 with 5 years of diabetes and no reflexes in the arms. Patient 2 with painful and weak proximal legs. Patient number 3, 10-year history of diabetes, absent ankle reflexes, vibration loss distally, and some toe flexion extension weakness. So a little bit dropped reflexes and a little weak in the, so all the above or 2 of the above? I hope not, none of them.
Number 3 is typical PMR. Number 2nd is PMR, which you can avoid. So instead of waiting for you for like 2 months or 6 months, I have a steroid and in 2 days they might just behave. No?
Yep, fair enough. Yeah, very much could be that case. And yeah, I'd go ahead and start them with a steroid. Make sure you check their CK levels if you can to see if there's a myopathy in the background that might need further attention. hip x-rays for osteoarthritis that can sometimes go ugly? Okay. Prab, is it uploading? I don't know if my web page just doesn't upload. Okay. Anyways, we have engaged there. So what I was looking here is 2 of the above. Okay. So a diabetic that has dropped reflexes in the upper arm is a little bit strange. It usually, if we're talking about a diabetic neuropathy, we're talking about lower extremities gradually moving in a stocking glove. And then I love that we've got already action in play for the proximal weakness as well. So yeah, it could be PMR, myopathy, inflammatory neuropathy, okay? So continuing on, we want to start thinking about localization here now that we're done about triage. So this is another case where essentially we've got 75-year-old guy, spinal stenosis, cervical level, lumbar level. You don't need to read all the details. You just see a whole bunch of moderate to severe at pretty much a couple levels, both stenosis and foraminal. He's already had PMR just to get that ground covered. And then he's got some lower back surgery on top of that. And so I get a kindly worded by so last 2 months worsening. He'll need nerve conduction and EMG. MRI has been ordered. I don't know what that means by worsening, by the way. But this is what I call a neurological delight scenario where I have to really put on my hat to think about all the things that can be going on, okay? And it was a long summary letter for all the things that were going on for that guy. So approach to localization. I'm going to go over a couple approaches that you might have in mind. But I want to, if nothing else, just do a refresher of medical school, okay? Or what you did in residency. Like, what is the approach? And most of us as neurologists, it's just so there that it's in every one of our consults, okay? Cranial nerves, motor, sensory, coordination, gait. And again, now, of course, as family physicians, you have less time, but I just want you to have that framework. You can script the cranial nerves that is appropriate at times, and then hit the highlights. But just keep that in mind. So first off is maybe just keep in mind, let's talk about either weakness or per se. So what's the distribution? Is it just distally, maybe down in their feet? Is it, as we've kind of already made some connections with distal and proximal, okay? Or is it patchy or focal, right? Does it seem to be just in the hand, just in the foot? Or patchy seems to be, something on the left and something on the right. And so then that starts giving us clues about maybe just a standard axial polyneuropathy, not too much to worry about in general. Then proximal, all right? We talked about the red flags there. And then we talked about patchy. Now, patchy might not be too problematic if you have a classical CTS distribution, but if you start seeing fasciculations in the arm, you might start thinking motor neuron. You find that, you dust off that tendon hammer of yours and you find that those reflexes are higher than you would anticipate. Maybe there's something else going on. Or you do the reflexes and they're dropped, and so maybe you start speculating about a plexopathy. Okay? So another approach to thinking about this, so I want, by the end of the night, we'll have these all memorized and committed to memory. This is just my slide about my love for neurology that has what I call the double differential. So we get to localize, and then within the localization, we get to differentiate again. So that's my pleasure that you guys can leave to us. I've alluded a little bit to this. So with a pattern, we might also think about it from a structural standpoint where we're going to, so I don't lose the mic, start from the spinal cord and move yourself out, right? Out, so anterior horn, into the nerve roots, into the plexus, into the individual peripheral nerves. And then if you want to go next step, neuromuscular junction and muscle. So just a few highlights. Again, reflex hammer here. So if you see some fasciculations, please, I implore you to tap some reflexes, see if they're disproportionate, asymmetrical, upgoing toes, because we might be talking about a motor neuron condition, okay? We might look at the distribution of sensory and even autonomic stuff at times for general peripheral neuropathies. At the neuromuscular junction, we're not saying, oh, I get tired after the end of my workday, but have them do 10 shoulder abductions, have them do 5 or 10 hip flexions. Do they fatigue in your office after just that? That does not take too much time, and you have potentially myasthenia gravis without the whole ptosis, diplopia, bulbar symptoms. And then we've got the proximal weakness for some myopathies commonly. So one thing that we'll reflect back on the EMG, okay? So I can't leave this podium, so I'll use my mouse. Is the category I can touch with my nerve conduction studies. So your alpha fibers, okay, your large myelinated fibers. But then when we start getting smalls, notice cold perception, pain, again, another pain in your A deltas and C fibers. Unfortunately, you can have stone cold normal nerve conduction studies, and still they are verifiably having a neuropathy. And then you get into the even meaner world of autonomic dysfunction with smaller fibers that we can barely test on tilt tabling. Okay, so challenges with sensory testing. I'm going to throw it out to the group again. Oh, getting to 20 minutes. So what in your practice have you found is the challenge with sensory testing? So I understand that you guys at least have tongue depressors, so you can crack those bad boys in half, okay? Make sure it's sharp on you to start off with, because if it's not sharp on you, don't be surprised that the patient thinks it's dull, okay? If you have some safety pins, those can be useful as well. No one in our practice group had a vibration hammer or was willing to suggest that they had any ownership of such things other than their pianos. So we've got our tongue depressor. What's going to be the problem with actually doing it? I know there's a time crunch, so that's always one thing. Have you ever done it on yourself? Have you ever done it on yourself on a repeated basis? Have you done it with different tongue depressors? They can be different, okay? So number one is have a bit of an external and internal control. So test it on yourself, okay? Also, if you're doing that with the safety pin, patients like that they don't see that you're drawing blood, and also knows how much you should press. Another element is test it on them. So I have some patients, you test them up and down. Nothing's sharp, so good luck on getting an actual valid examination. So the other thing is, so you can just give a control, okay? What's their chest wall, maybe their forehead, maybe their thigh. Those should be, in all likelihood, preserved, and then you can compare. Especially if they have a rather advanced or long-standing neuropathy, you may only note the difference. They'll say, oh yeah, it's sharp, but when you test it at their thigh, they're like, oh, that's actually sharp. The other thing that you can do is discriminate, and that means flip that tongue depressor around, touch the dull end, and versus the sharp. And you'll have people that will say, oh yeah, that's sharp too when you press the dull. So you've got some problems with their sensation. And so this is not your monofilaments, although there were some in our group that had monofilaments. How many times you poke them? I can't keep track of too much information with poking individuals, so I kind of keep it to 3 in the lower extremity, 3 in the upper extremity. So that gives you a proximal to distal gradient, and if you're slick, you can pick points that are within specific dermatomes as well. So there is fatigue that starts happening. There's language barriers. That's why I've got a few Punjabi phrases just in my vocab to help me along. And then, like I said, variability, and for some things with temperature can be an issue, but you're not testing that. So we're going to go into large fibers. So there was some desire to know what gives me a clue that this is a large fiber. Well, what do they do when they're walking at night? Are they furniture cruising? What happens when they're in the shower? Are they holding on to the walls? Okay. What's it like when they're on uneven surfaces? Are they needing someone to hold on to? Are they finding that when they're starting to get difficulty recognizing something in their pocket? That might be a bit more advanced question, but you'll also hear the sensation. I'm walking on pebbles. I have blocks or stumps as legs. Okay. Some people will say it feels larger, okay, or puffy. So our next question here. So again, if Slido is working for you, throw that in there. I think we're going to get a chance to review that afterwards, the utility of this tool. Okay, so number 1, what's small fiber here? So temperature pinprick. Number 2, vibration touch. Number 3, joint position sense. Number 4, sympathetic, parasympathetic, all of the above, or 2 of the above. Okay. So if you remember that little diagram of the tapering size of the axons and myelination, you will remember the temperature and pinprick and the sympathetic fibers, okay? So that leaves also to note, I said use something sharp, okay? So that's just so that you have some quantification of small fibers, but then you're using your hand or cotton or towel, whatever you want to use for your light touch sensation. Okay, and then small fiber stuff, so we're talking about burning, electric shocks, okay? So you can do this demonstration one of 2 ways to illustrate a point. So if you have a partner beside you that you're comfortable with, I'd like you to grab their forearm and twist their forearm in different directions, or if on yourself, just take your muscle and twist it, okay? And tell me, what pain is that? Is that small fiber, large fiber? Is that arthritis? What is that pain? Okay? So when next time you're not sure if this patient is actually telling you something after their motor vehicle hurts, remember this, okay? Sometimes the connective tissue distorted and held in a position for a long time. That's for just a short period, right? Keep holding it. Then you start feeling it's heavy, okay? So if anyone has done, I don't know what the exact term is, but it's essentially weight training with a band restricted, you'll start getting a sense why they get this sensation of feeling heavy and weak. Okay? So I think that'll be a good point. I'll pause here for some questions. Do we have anything on Slido that, let's see if I got. Apparently the only thing I see here is 4. Okay, should I press on? Okay. All right. So we'll go into our case 3. So time-wise, I have myself at 40 minutes here, so I'm going to maybe realize I'm going to have to break this off to another talk. But let's just use this case to highlight some things, and we'll skip the next case. So this is a 34-year-old window installer. Okay, so he had this episode where he bent down, and next thing he knew, he's not working because of the pain that was going down into his leg. And the referral here specifically said MRI revealed a L5-S1 disc impinging on the right S1 nerve root. Patient has done physio, kinesiology without improvement, evaluation and treatment from neurosurgeon, which I'm not, so I don't know what happened. And this patient was from Chilliwack, but this patient has also had a rocket doctor. So I said, this is not my jurisdiction, but I don't know how to talk to the rocket doctor back, so please come on in. So, and this guy still has some ongoing issues and not sure, but he's had previous back pain. So this is, again, I'm sure this patient bounces back to your office. What do you do with them, okay? And they've gotten their designated meds, but it's not just about their pain scale, it's about their function. So, okay, I'm going to just pass through my radicular pain issues here. So we're going to talk just a little bit, just review about pain patterns, okay? So I just want you to take note of some things like the S1 here, kind of on the back of the leg, L5 down the side of the leg, L4 also including some of the inner, again, below the knee. So just keep that in mind because we're going to talk about what else that could look like. Keep in mind, red flags, weight loss, night sweats, B symptoms that might suggest that there is a cancer that is going on. Again, if there's any IV drug use or other immunodeficiency, again, if they're on prednisone for your PMR, there could be infections. If they're longstanding diabetic with poorly controlled, I consider that immunocompromised. Okay, if they have another condition like lupus that they're on some, again, we learned today, particularly from our rheumatology colleague, it's the steroids that are really the most risk factor for potential infectious. Okay, and then there's our things like zoster that can certainly give a lot of problems, both short and long term. So now the other issue can be, so they did this study where they took some willing participants, apparently. I imagine they got fed well, but they stuck contrast into the facet joints and just expanded the joints. And they started to map out with colorful textures here where their pain was for various distributions, okay? So there can be just the facets that are being an issue, right? And often, again, I'm paying attention to foramina and spinal canals, but the facets themselves could be problematic. So keeping those in mind, that if they potentially match some of these patterns, that it might be worthwhile getting a nerve block from our anesthesiology colleagues. And then I said, remember that image. So I'm going to pop this off. And we have out here, I'm not going past this line, just at the gluteus minimus, okay, that we have two different sites, one that looks awfully like L5 and one that looks awfully like S1, but those are muscular. Referred pain patterns. We learned about them, you know, cardiac, gallbladders, all that stuff, but there's a huge host of myofascial or muscular pain patterns, okay? So if you look off even down into the lower extremities, right, the little X marked down by the adductor hallucis, you remember those toes that people complain being numb or painful? Maybe it's a muscular issue there. So, and again, I may not really pick up very much because my muscles, my nerve studies go right where that X is here, this guy, okay, or for those that are right there. But that's not going to necessarily detect a problem. Okay? So we're going to go into just reviewing the upper extremities. Okay, so there's the same case here where now this is a lady that's seen me before, and she's had a rotator cuff strain. Okay, so she's had some increased workload despite the strain. She indicates that there's pain radiating on her shoulders right down to that index, and I'm like, holy grail, C6, here we are. And then there's this giveaway weakness on the shoulder, which I'm like, damn, this always kind of makes it hard to really be confident. And we do the EMG, and yeah, there's a little bit of change, but nothing too dramatic. But she's got imaging that matches, and she's got a positive Sperling test for, again, rotate, tilt, give some compression, reproduce the symptoms, okay? And then she's got a positive to Nels to boot. So that is one of those kind of pick your adventure of what is the issue, right? So C6, right? We're, again, index and thumb along the lateral arm. And here you can have reproduction of some of that stuff, but remember that torn rotator cuff? Maybe it's supraspinatus. Okay, maybe actually we've got something in teres minor going on back there. Okay, infraspinatus. So we've seen a lot of those tears. So one thing that I might suggest you guys to do is consider looking at ultrasound imaging of the shoulder where those things are going on, and then having someone that's skilled with the shoulder and the whole global system, I should suggest, so that they can potentially start alleviating. If you get a history of how they can change it based on position, and often they sleep on that side, they get reproducible symptoms, I'd like it to start percolating higher up in your mindset that it might be more muscular or myofascial. And then this is a nice diagram how even things through the chest wall can have a lot of referred pain. And so here they injected hypertonic saline. So this comes from the work of a cardiologist, Janet Travell, and partner Simmons. So just briefly talking about carpal tunnel, you guys are pretty much doing it all right. So referrals are all good from that. But I do want you guys to look out for again, atrophy, okay? So hopefully reasonably depicted here. So just use your own thumbs as an index for that APB, okay? A test, this is a high yield test. If that's weak, again, that's going to be helpful for you to know. Notice that some patients will use their extensor. So if they're pushing back that way and not pushing towards their own body, they're potentially compensating, okay? Now, osteoarthritis is going to make that potential appearance as well, so there's issues that way. And then you're going to get higher yield if you're doing both Tinel's type test, okay? So having the elbow extended and the wrist flexed back, and as well as doing compression, okay? That's going to be your highest sensitivity specificity testing. But you know what else is highly sensitive and specific? Doctor, I have to do this when I wake up. So sometimes you don't need all these fancy other things in 30 seconds of compression that you don't have time for. But I want to implore you, again, maybe think beyond that. What makes the carpal tunnel tight? Why are they having this connective tissue tightening up that a surgeon needs to open up? Okay, and once again, maybe go into their flexor digitorums that run through the carpal tunnel. Maybe that's causing their wrist to lock in this way at night and you're giving them the nocturnal wrist splint. Okay? Maybe their pain is actually in the APB because they're compensating through some task that they don't have from their pronation. Okay? So pronator teres, this is we're en route for that median nerve, okay? And maybe it's there, maybe they got a bad blood draw, but maybe it's something else that they do in their work as an electrician, screwing in things all day. Ulnar neuropathy. Again, one thing if you want to be fancy for your testing, okay, is just your flexion of the elbow and compression. Actually, it doesn't have to be full flexion. Actually, that gives actually slack to the ulnar nerve, in fact. So having it 20 degrees and then holding compression. Okay, 30 seconds is enough with quite high, above 90% sensitivity and specificity if you start getting paresthesias in here. Okay, but once again, what's around those nerves, okay? So you've got flexor carpi ulnaris en route. There's an aponeurosis that nerve has to go through. If it's snug there, that might create a catch point. If you're in the triceps, that's another potential catch point. And then, of course, in the thoracic outlet is a whole other talk, okay? And there's all these kind of lovely tests. One really easy one, just have a piece of paper between their fingers and see, can they hold on to them, okay? And if they have to flex their finger to try to hold on to it, that means some of their interossei muscles are weak, okay? There's a Froment sign, that same kind of idea. Instead of them actually being able to hold down here, they use the FPL median strategy where they try to hold that piece of paper there instead of being able to hold it flat, okay? So those can be maybe quick tests and they can be good at picking up earlier motor weakness in addition to a history of, oh, I can't use my clippers, I can't open up jars quite as well, the keys are a bit problematic, thank goodness for keyless remotes. Okay. And then if you want to be really clever, you can actually feel that ulnar nerve. It's like a spaghetti popping in and out. So if they do, for whatever reason, lean or flex their elbow and also have this nerve that pops out because of the tension, then yeah, they can be doing double duty. So this brings me to non-pharmacological management, okay? And this pretty much hits most of what the ideas are, okay? So I want you to consider expanding out of your typical pregabalin, gabapentin, amitriptyline regimen, okay? Because that's really what mostly out there, because I'm pretty sure most of you don't want to give tramadol and opioids, neither do I, okay? And then third line is nabilone. That's the pharmaceutical talk, okay? We'll talk about it just so slightly afterwards. So after that, you've given those ideas out there, start expanding. What else can they do? Maybe for peripheral neuropathy, particularly for the diabetic peripheral neuropathy, there's some suggestive evidence for red light therapy, okay? Unfortunately, red light therapy at 880 nanometers penetrates about 5 millimeters deep, so don't expect that you throw it on a big muscle group and that you're gonna have some wow change, okay? But down in the feet, maybe in the hands, maybe thin chest walls, if there's pain there, you could consider. TENS, again, high frequency TENS can be a reasonable thing for them to do, especially if it gives them some agency for their pain. I've had some patients walk around with ongoing TENS machines. If that helps them function, maybe then that's not unreasonable. Acupuncture, again, there's some interesting overlays with fascial lines that acupuncture may touch. If they can afford it and have a good practitioner, I think it's worthwhile to try, because there are a lot of areas that we just, again, for anything that you write in your report that says non-specific, it's worth your while to potentially extend to your allied colleagues, whether it's chiropractors that do more than just adjustments, osteopaths that have kind of a diverse look on the myofascial system, acupuncturists, and also physiotherapists that have stepped out of what I call the factory cookie cutter type of physiotherapy, and they're doing more than just slapping heat, ultrasound, and they're actually looking at the whole body, looking at the biomechanics. And so that is kind of, for instance, on the bottom left corner, you have L.J. Lee doing connect therapy as one kind of idea. You have another branch of rehab with dynamic neuromuscular stabilization. So just look for people that are looking a bit further, okay? And so that was those ideas. Now, the other thing that as a family practitioner you can do is encourage, commend them for efforts, and help them see that they are making progress in spite of their tendency, as we all have. They walk into our office and they tell us what's bad. I sometimes tell my patients, tell me what's good. So let's start there, okay? Because there are good things we need to remember so that we're motivated to do things. And so I use the word movement therapy to distinguish from exercise, because I tell my patients, I do not care if you are sweating, short of breath, or sore. None of them are required and perhaps are problematic, because any of those things might discourage you from doing this thing again. The other thing I tell them is habit formation, okay? A lot of us wake up, we're making a coffee or tea on autopilot, we sit down in the evening, watch a show, read a book, listen to an audiobook, we brush our teeth, all autopilot. Well, let's autopilot 2 minutes of something that stimulates or challenges the body, and when it comes to a weak area, a sore area, 2 minutes may be more than enough, and 1 week, 14 minutes of directed awareness in this area might be quite a bit, but will allow for slow progress. So this comes from Atomic Habits by James Clear about habit formation and breakage. You can have, what I tell people is do not push through pain, okay? It bothers me to no extent when we have a culture that says push through pain. I would encourage you all as family physicians, teach them how to move, or help them, encourage them to move without pain. Find where is their limitation, how can they modify? Do they drop the weight? Do they change the range of motion? Do they work on a different part of the area that is a supportive structure, i.e. my shoulder hurts? Well, work on the rib serratus muscles, work on your lower trapezius fibers, rhomboids, to support the shoulder blades so that your deltoid bicep tricep isn't overworking and crushing a nerve and causing you for a referral to a neurologist. So there'll be elements where they think there's a lack of progress. So again, record the positive points that they're making. And emphasize something that I actually learned from our working group, which is change process. Come 1 second. Which is this idea that things happen when you implement a change, see how it goes, and then you come back to it. Step 1, though, is implement the change. So that's what the habit formation is about, okay? Then you tweak, which is those modifications and those concepts about what it means to make progress. Yes?
Medications such as Bogusz. Did you have experience with peripheral neuropathy, specifically post-herpetic neuropathy? Did the Bogusz help?
Yeah, so I didn't do a deep dive into the neuropathic pain for that, but there are, if you consider headache peripheral neuropathy of such, which I do, then yes, but the challenge is the application. So how much, where are you hitting the distressed tissues? So the distressed tissues certainly do get some improvement, but you don't want to make them too much weaker when they're fighting against other restricted tissues that are So it's what I'd like to get to in my practice is to the bottom of the problem. So if you're using it so that they get bandwidth, though, so that they can do that, right? If they are just exhausted by their pain, by sleep is destroyed, etc., and Botox will give them that bandwidth, and then you can encourage them, yes. But I think I'm still playing around with it. It does work at times. You have to be cautious about it, though. Okay. So change progress, I emphasize change is slow, okay? And at least once they realize that change is happening, then that's important, okay? Because if they go, get pain, come back, feel worse, they're gonna stop doing whatever the physiotherapist you recommend and so forth, okay? So, and I can go ad nauseum about this. So modify that change process idea, okay? And modify the assumptions, okay? One assumption here that I seem to, maybe is incorrect, but people feel like exercise or movement is there's nothing in between sitting and walking is the be-all, end-all. Yes, Health Canada can make those recommendations for moderate exercise, but that doesn't apply to many people that are in pain. You have to find some recommendation. Thank you, April. So, and then connecting with the therapist here can, for those that need that social, that kind of accountability, this can be a really important role, okay? And those that have forked over money for it. So I'm going to, maybe we'll finish on the Slido here and we'll entertain questions, and I've kind of gradually ripped through pharmaceuticals, which we'll have time for elaborating on. But Slido question, okay? So which of the following, from my belief set here, is most required for recovery? So number one, a chiropractor does active release and gives exercises. Number two, a therapist that does manual release and encourages the patient to push through pain with exercises. 3, a patient with a sense of agency. 4, appropriate pharmaceuticals, injections, and/or surgery. Number 5, red light therapy, acupuncture, massage therapy, or all of the above. And actually, I'd be really curious to see what you guys say on this one. So let's see if my Slido thing will. So I see 16 people have answered, but I don't get to see the, oh yeah? Okay, yeah, so that's great. I'm glad you guys got my drift. The sense that patients can actually have ownership, that change can happen. And you can absolutely, with the second answer was all the above, and I would agree. Just look at all the above, because sometimes, yes, I'm not foregoing pharmaceuticals or injections and surgeries, but that's not the only thing, okay? And we can, so even injections like facet blocks or intra-articular nerve blocks, they work, they reduce pain, they can help function, they can reduce depression, anxiety, but then the pain comes back for a number of patients. So what are you going to do then? Where is their agency? How do they stop visiting you time and time again and be able to depend on themselves for improvement of their symptoms? So I'll pause there to open the floor to questions. If not, I've got some more slide material I can certainly cover. But I do appreciate the opportunity to go through this wide range. Okay. So again, I'll read off some things from the slide deck, but we will feel free to pop up your hand, okay? So number one is, would it be okay to send patients for probable diabetic neuropathy to characterize their deficits with EMG? So yes, once in a while I get that. But that might be better for, number one, for coastal clinics or just a clinic that's just trying to go through. But if it has things like asymmetry, prominent weakness, the only thing that really doing that nerve conduction study is, do they have some factors that, A, you didn't notice, they also have carpal tunnel going on or ulnar neuropathy because they've had studies and an examination looking for those factors. And the other thing I would say is, for a small subset, they might have some issues with an autoimmune neuropathy. So that may mean they actually would respond to some IVIG or in select cases other immunosuppressant agents that can help them. But usually those individuals are fairly affected. So I would say for most, very slow, progressive. But if you have like, again, a referral that I get quite commonly is like this person has quite a bit of pain and dysfunction. And dysfunction, by the way, means their sleep is impaired. They can't sit very long. They can't stand very long. They can't walk. They can't sit in a car. That those individuals are potentially good to, well, certainly see myself and colleagues, see if there's anything else that could be in the mix. Okay?
Question.
Yes?
Let's say if you get that EMG, for follow-up, you just follow them up clinically, would there be any value to sending them again for a EMG down the road?
So it depends what comes out of that visit, right? So if they have something that's a fairly, borderline ulnar neuropathy, I want to see them again. If they have something that's a carpal tunnel that they want to sit on the fence and we should probably be doing surgery, I want to see them again. If they've got a dropped foot and something else looks funky, like their reflexes are up and maybe this is actually motor neuron disease mixed into it, I'll send them again. But most of the colleagues will say B12, SPEP, A1C, best of luck to managing their diet and sugars, send back to the capable hands of our family physician colleagues. All right, another question is, would you prefer a 10-gauge MF or a broken tongue depressor for sensation testing? Are there 2 or 3 high-yield sensation tests which you recommend? So I would, if you have a 10-gauge and you easily can access it and you've kind of standardized it to yourself, then go ahead and use that. I think you're going to more likely grab the tongue depressor, and so I would probably stick with that. And like I said, high yield tests are going to be just those 3 points. So having something on potentially, again, dorsum of the foot, some aspect of their lateral leg, and then above their knee. And in the hands, again, maybe I lie, it's a little bit more than 3. Okay, I would do D2, D5. I do a palmar as a comparator for these guys. I do something in the forearm, and I'll do something in the arm. Okay, so that tells me, again, it also tells me a bit of C6, okay, C8, and again, I'm back into C6 or C8, depending what I look at here, in C5. So I get a little snapshot of, and if you want to do the back of their hand for some C7, then away you go. Okay. What's my experience with prolotherapy for myofascial pain? This is another area I haven't done a deep dive. So what I will answer as a workaround is that, for instance, they've done studies comparing dry needling. Okay, so this is with kind of like acupuncture needles where they have the pencil tip, and versus what they call wet needling, where again we're typically using medical needles with the bevel cutting edge and injecting something, okay, bupivacaine, normal saline. And the studies suggest that the pain management is similar. I'd say the experience is different, and I have some arguments that depending on what you're treating and how you're treating, that there may be benefits in having a cutting edge attached to it, which allows for breaking scars, connective tissue densities, and actually just arriving at the point that you wanted to actually needle in the first place. The prolotherapy, again, it might not be what you're injecting and the theorized stiffening of the tissues in response to the glucose or whatever agent else you might be adding in there, but it might be just the hydrodistension within the fascial layers and the fact that you're also using a needle that's doing that. But it is an area that I want to look into a little bit further, because what you inject, how you inject is pretty curious. Where do we do EMGs? So certainly neurology colleagues, Jim Pattison, Coastal Clinics. There are some also for if you're having some wait time issues, so physical medicine and rehab. If you're North Fraser, you've got Toth and Chahal. If you're South Fraser, Dr. Sherry Wang, for instance, does it by Fraser. So you can certainly use those colleagues too. But if it looks complex, it's going to be, I've seen ones just deferred back up to us, okay? And then convenient ways for temperature sensation. Honestly, if you have an ice machine, that's the best thing. But if you do have that tendon hammer, anything cold in your office, okay, just use that. Honestly, in the hospital, I've picked up a butter knife and used it. It's just something that feels cold to you, and you can use that as a reference point. The one caveat I would add into that is when you are testing peripherally, feel if their feet are cold, and then you put a cold object and they say, I don't feel it, the contrast is missing, right? So if you feel up their leg, and you notice that now they're getting warmer and then they can detect that cold, it's not necessarily a peripheral neuropathy, but there is something to say about people that are always cold. And in those cases, also with claudication type pain, please palpate for blood vessels. That can be a very valuable find. Again, sometimes as a neurologist, even it doesn't get to my mind early enough. And then, is there a routine to send for yeah, so SPEP and UPEP I would send for routine. Now you'll find that there's going to be a lot of slightly above high as patients age. Monogammopathies are quite common. So if you want to give up the rest of your ALT, AST, LDH, beta-2 glycoprotein, and they do have something concerning in their hematological profile, then you might have evidence to have a hematologist. Otherwise, I'm seeing bounce back letters from hematology saying that's not good enough for us. We're not going to bone marrow biopsy this poor gentleman or woman. But yes, so B12, TSH, A1Cs, and then I'd throw in other things like celiac as well. Again, that can be a low yield thing for some neuropathies for patients. And then we've got rank the efficacy of gabapentin, Elavil, Lyrica. Okay, you guys wanted me to show that slide. I wanted to scare everybody with some organic chemistry as well. So this is 2005. What the size of the circle indicates how many studies were there. You see some stuff for tricyclics. You see a whole bunch of things for gabapentins, and then NMDA antagonists, which I presume means ketamine, and then some things like the antidepressants. And then fast forward to Canadian guidelines here showing, lo and behold, gabapentin, tricyclics, SNRIs, specifically duloxetine and venlafaxine. Second line tramadol opioids, which again, not even in the guidelines, they're like, please refer to opioid management suggestions. So it didn't have a high vote of confidence. I'd say cannabinoids, so nabilone might have some interesting benefits for patients. And then the fourth line agents, those are the anti-epileptics, carbamazepine, valproic acid, but also things like lidocaine patches, so those that like Salon passes and so forth. So there is no clear rank order. This is just as good as it gets for that. It also depends on, there are a couple studies that say for post-herpetic neuralgia that, there's going to be some better benefit for one versus the other, but it's going to be a bit of trial and error based on, their response sensitivities and the like. There was one question signing up to this that was like, when do you get to 50% or 90%? Like, how do you know, how much time do you have to pass to get 50% of people getting benefit, or up to, and how much time before you get 90% of people getting benefit? And I can only kind of relate two things. Is one, my practice, which is reflected in the guidelines. Two is, escalate. So for example, say in gabapentin or the like, start at 100 milligrams and escalate every week by 100 milligrams TID. If they're, again, rather insensitive, maybe escalate 300 TID. And as my mentor, one of my mentors in residency said, if they're in hospital, it's Texas style, go big or go home, okay? So we just ramp it up like every 2 days and see until they hit side effects. So it just depends on how reliable this patient is. They have caregivers to see that they're getting too drowsy or the like. It should technically, right, 5 half-lives. Again, there isn't typically a biological effect that's delayed per se. So it's more about, as many things get effect but not adverse effect. Gabapentin for pregabalin. Yeah. So as you may recall, gabapentin, the trouble is more about consistent, you get what you consume, in the sense that it's not proportional, the dosage, in terms of how much is bioabsorbed with the gabapentin. So that may be the downside along with the TID dosing. One thing I would say, one recommendation that's come out in chronic pain management that I've seen is having some split of your, say for Lyrica or gabapentin, that you load less, maybe 1/3 in the morning and then 2/3 in the evening. Again, that's just to reduce some of the sedation, dizziness effects that are going on. Yes?
I wonder what does it take for the comparison of gabapentin and TCAs? Because if giving a TCA at night.
So if you have an 80-year-old patient with a heart condition, I'd go with gabapentin, right? So there's the patient-specific elements. And I'd say, again, if they've got another thing where they have difficulty sleeping, I would be going for TCAs where appropriate, especially if there's some mood and anxiety around that. There's a couple patients that have that. Whereas the gabapentin, again, if they're a retired individual that can take something TID along with other medications, I might start with that in terms of responsiveness with a little bit less side effect profile. Little bit less, okay, right? So I don't know if you remember I think it's called the Therapeutics Initiative. It might have had changes. I remember in medical school that they published ones of the evils of pregabalin and gabapentin too, so. And then it becomes like the evil you know, the devil you know. So, and that's why I also still promote this other stuff, right? Because you want to find, like, drugs have just only so far they can go. They come back to you, what else do you offer them? And you know when you're winning? When they tell you, I've reduced my gabapentin, and you just enjoy the luxury of hearing somebody go down on their gabapentin, savor it, okay? Same goes with their amitriptyline, okay? So again, these types of approaches, when you start, again, I've been fortuitous to have the company of patients that are going down on Botox, stopping some of their CGRP antagonists in the context of migraines, right? I have patients that had chemo diabetic neuropathy. They went and they got a massage at Bigfoot and brought me into attention, oh, if you manipulate the tissues, you might have, your chemoneuropathy might get better, but you got to try, right? You have other people this gentleman that I talked about, 88 years old, spinal stenosis, at his cervical lumbar spine. You know what he came back to me ever so proud about? I love this. He's such a showman. So he had a piece of paper folded in 3, okay, and he's been using some pedometer, and he's telling me, you know, what his walking. So, you know, month 1 is like 3,000 steps, okay, and then he's like, next month, I got an idea. I'm going to try a walker while I do this. So I was like, man, you're walking without a walker? But, and then he's like 7,000 steps for month 2, right, as he unfolds the paper. And of course, you know, with the 3rd fold, he's like, so how far did you think I got next time, right? So he got up to max was 14,000 steps, okay? So that was by month 3 of just gradual. He didn't always walk, again, I know walking, yes, but you know what I said about that. But he's doing other things that are movement therapy that build the capacity to do his walking, and he's using tools to aid and make it, and he's taking breaks. He's not doing continuous walking. And so he's able to make those changes, despite cervical lumbar stenosis that no surgeon's going to touch. You know that, right? So, so how do you decide to image if there's bilateral asymmetric upper extremity, lower extremity weakness, and no bulbar weakness? Do you have some more context to that one? Because there's a lot of roads I can go down with that. So the short answer is, do they have dropped reflexes, okay, or do they have high reflexes, okay? One scenario, they might have some weird asymmetry from a cord compression, okay, and you might see normal reflexes, so to speak, and then, you know, brisk knee reflex, maybe a beta clonus and an upgoing toe, and that's going to say spinal imaging, okay? Cervical, thoracic level likely. And then you might have dropped reflexes, which likewise you're looking for that nerve root impingement. That may be a surgical discectomy, fusion, whatever it might be. So I'd say that reflex hammer is what compels me to potentially do imaging. Your additional special tests like your Sperling, your straight leg raise, again, are going to also move you into that direction. But ultimately, you want to see that there's, once you've got some asymmetrical weakness, you can put a timeline for your radiologist to say, please book in, what you think is the appropriate timeline to get things done. But giving that information to the radiologist will help actually expedite it, and because you've taken the time for the reflex and examination. Can you combine SNRIs and nortriptyline? Yes, just low dose. Sometimes you can get away with that. The studies don't suggest that so in this reverse slide, one of the little asterisks on the side there says, consider adding sub together. There's not a large amount of evidence of combining. We do it, but I don't find myself, outside of having two agents, that, I would start class switching, right? So if one agent, whichever one you think isn't working or giving too many side effects, pick something, maybe go into the navalone, maybe you will do some low-dose tramadol or something like that. And then, can muscle fasciculations be normal finding ever? Okay, so who here has had fasciculations? I'm raising my hand because I've had fasciculations. In fact, I've had some fun ones just in the last little while, just in excitement of this presentation, okay? So yes, fasciculations can be normal. So especially what we want to see is the context of motor weakness and fasciculation. So it's an excellent question, but it's really imperative that there is some motor weakness associated with it. Now, patients will also, with other kind of chronic neuropathies, like polyneuropathies comes to my mind from some patients, post-MVAs, they'll talk about fasciculations. And this can be potentially because these nerves are being irritated for a period of time and then released. And then they're trying to kind of reconnect. And the muscles, and sometimes as people are actually recovering, they'll get pulses and twitches that can be seen when you do trigger point injections and IMS. So sometimes these are positive things. So it's just about trajectory. If they're getting obviously weaker, please send them us. Those are prioritized. We try to get them in within 2 weeks, if not a month, if you're clear on the history. All right, I'm at the end of my Slido deck. I don't know how we are for time overall. 1:18. Yeah. Is there any other questions? Yes, Larissa. Yeah, so I thought about this question and I say leave that to Greenleaf Clinic to talk to them about it when it comes to, but like most things, if you want to look at that, number one, I do find it needs some degree of THC probably to have a central blockade effect, but start very low and go slow. I can't tell you whether combining with the CBD component is more helpful. There are some effects that it magnifies some elements, but I don't know if the neuropathic pain relief is benefited as opposed to just the neurocognitive effects. So I would typically stick to the navalone. You know what you're getting. You have evidence behind it. That's where I would prefer as a recommendation. Yeah, so that I have been fruitful for some people that helps for sure. Well, thank you for the lovely company this evening. Certainly give us any feedback that you have about the talks, things that you want to hear in the future. Like I said, this kind of feels in preparation that this was part one. There's a lot of other elements that we can try to do deep dives and try to answer questions as best as possible. But first and foremost, it's just great to see a lot of people in person, face-to-face, as opposed to Zoom meeting. So thank you all for coming out this evening.